Thank you for joining. I can see people are still entering into the webinar. It's actually now exactly 6 o'clock UK time. We know that there's actually quite a few people from outside of the UK joining. We've seen quite a few people from a wide variety of countries. So very much welcome, of course, everybody to this webinar about assessment of ADHD in children and adults using BGaze ACE, which is basically a digital AI-enhanced version of the long-standing tool developed by Susan Young, ACE and ACE Plus. Basically, we will have today two speakers. The first will be Susan Young, getting into the tool ACE and ACE Plus itself. And afterwards, we will have Hans Supèr, he was actually the CTO of BrainGaze, who will explain in more detail what digital technologies and artificial intelligence can actually bring to the use of rating scales, to the use of a tool like ACE. So I would say without further ado, I'll stop sharing my screen, allowing Susan to start sharing hers. And give her a brief introduction, of course, while Susan gets her slides up. Professor Susan Young is, of course, a long-standing expert in ADHD, both in adults and in children, clinical and forensic psychologist, practitioner, neuropsychologist with over 25 years of experience working in clinical academia. She left clinical academia at the end of 2017 and has since worked full-time for a private practice as a director of Psychology Services Limited and Psychology Innovations Limited. I won't go into the full CV because it's too long, Susan. You've done an amazing amount of things. Yeah, I would say most people around the world know you very much for your work in ADHD, but you have done quite a few things beyond and above that. But for the sake of time, I will leave it at this brief introduction, and that's already right from the start a big thank you for making your time available. And I'll pass on the word to you and the screen to you.
Thank you very much, Laszlo, for inviting me to come and talk to you all about the ADHD Child Evaluation, fondly known as ACE, and ACE Plus, which is the version used to assess ADHD in adults. I developed these measures because, you know, there really are limited measures that are available to assess ADHD in adults, but also but particularly in children, that are structured clinical interviews. And so many young people are being misdiagnosed or not diagnosed, underdiagnosed. There's so many problems with this, and I think sometimes it's because you know, these assessments are not consistent enough or not comprehensive enough. So I thought this might help people to sort of check the boxes and check and to, you know, guide them through their interviews. So what is ACE and what is ACE Plus? Well, they're semi-structured interviews in multiple languages, and many people will know of them already in different languages. I think ACE is currently in about 20 or 21 languages. We have several coming in that are at various stages of production for the hard copies to be translated. And I'm talking all the time about the hard copies at the moment because Hans is going to talk later about the digital copies. ACE Plus is in fewer languages because it was launched a bit later than ACE, and I think that's in about 12 or 13 languages at the moment, but more are on the way. And if anybody is watching this and you can't find ACE or ACE Plus in your country or in the language that you use, please contact us. And both ACE and ACE Plus are free to download from my website. You'll get my website link later on in the talk. Right, so they're semi-structured interviews, and I've also recently added pre-assessment tools, and I'll talk a little bit about those later. They're designed to support healthcare practitioners to assess and diagnose ADHD in children, ACEs up to 16 years, between age 5 and 16. ACE assesses the extent to which core symptoms of ADHD are impairing. So it's not just about having symptoms, it's important to note whether they impair somebody's functioning. And for children, this is both at home and in school. ACE Plus is for the over 16-year-olds. And here we're looking at whether the symptoms are impairing at home and in occupational settings. Now, in adults, occupational settings are not just defined as work settings. These are all occupational activities that are outside of the home, including paid and or voluntary work. It could also include sports and social activities. So that's what these two basic clinical interviews are, and I'm going to talk about them each in turn. To consider ACE first. And well, who do we interview? Well, when we're assessing a child, we interview a family member. This is usually a parent or carer, and the person has to have known the child for a considerable time. That person needs to be familiar with the child's functioning in different settings. So it may not be a parent or carer. It could be a grandparent. It could be, an aunt. It could be a brother or sister if they're much older than the child. Because bear in mind, that person that you interview needs to be very familiar with the child's functioning in different settings and across time. The child also may contribute to the interview. That depends largely on the age of the child, but I find it very useful to interview the child if I can, because you can get their perspective. You might not do it in so much depth, or sometimes I'll interview the parents with the child present. It all depends, but if you can get some kind of input from the child, then that is very helpful. You also, of course, you don't just need collaborative information. You don't independent information. You'll get independent information from school reports, from social services reports. Try and get some kind of independent information, rating scales that can be sent to schools. Some of you might know that I've just completed a consensus on females with ADHD, and actually a recording of me presenting the consensus statement is available on my YouTube channel, and you can watch it if you're interested. But one of the things that came out of that consensus is that, school reports may not be so accurate for females with ADHD, because female presentation is very much social relational. And school reports often focus on conduct and behavior. So you'll get a lot of information about male presentation there. Whereas they tend not to go into friendship issues and relationship issues and how they interact, so with teachers, etc. So just be mindful of that, and there's more about that in the female consensus, and as I said, you can watch that if you want to. So what's the fundamental organization of the ADHD Child Evaluation? Well, it comes in certain sections. So the first section is a guide for you to record background information. The second section relates to symptoms, the core 3 symptom domains of inattention, hyperactivity, and impulsivity. The third section is where you will record any observations that you've made. Maybe you've gone out and observed the child in a setting, perhaps at school or at home, or you've had the child in with you and you're observing certain things, so you can make notes there. Section 4 prompts you to consider comorbidity and or differential diagnosis, because when making this diagnosis, it's really important to figure out what might be comorbid and what might be the primary diagnosis rather than ADHD. So what's the differential diagnosis? Section 5 is all about scoring ACE and diagnosing. So if we go through these in sections, the background information prompts you to record obviously basic demographic information, family background, early risk factors such as premature birth, low birth weight, early trauma, head injury, prenatal mental health issues, maternal smoking, substance misuse during pregnancy. So it's quite important. And one of the most important ones I often think here is head injury, because that can often be missed if you're not specifically asking about it, or someone say, oh yeah, no, he was unconscious, spent a night in hospital or 2 nights in hospital. And I think that's that illustrates one of the problems with using some of the other interviews, because they don't include this background information. And I actually remember one young person who was diagnosed with ADHD, and in fact all of his problems had come from a head injury that he'd from an acquired brain injury that he'd suffered from an accident he had when he was quite young. And actually in the conversation they'd just forgotten to tell them, and that it wasn't in medical records, it was a private assessment, and this had got lost. So so I think head injury is quite an important one to ask about. It prompts you to consider, to get to the medical history, how they got on at school, their educational history, the quality of their peer relationships. And that, of course, is very, as I said, important for females. Section 2 takes us to the symptom ratings. And of course, as you probably know, there are 18 symptoms. And with each symptom, as you go through, you have to bear in mind 4 key things. First is onset. When did this symptom first appear? Because the diagnostic criteria require that symptoms are present before age 7 if you're applying ICD-10, or before age 12 if you're applying the DSM-5. Secondly, duration. Well, they need to have been present for 6 months or more. So you're thinking, do they have this? Was this present by age 12? And do they still have it? Is this symptom still present now? And has it been present for the last 6 months? So it's about duration over time. Thirdly, you're considering whether it's pervasive. This symptom needs to appear in more than one context, not just when they go to school and they're perfectly all right at home or everywhere else. So, or not just when they go to visit their grandparents and they're fine with you and at school. So it's about pervasiveness. And fourthly, persistence. The symptom must occur more frequently than typically expected of the child's age. So you need to be mindful of that. And I often think that's why sometimes, I remember a couple who had 2 children. The first child had ADHD and autism, actually, and they didn't really realize that their child had a real serious problem until the second child was born, and they had a benchmark. And because they were living in quite a rural, isolated place, they didn't mix with a lot of people themselves, and they didn't really realize how much of a problem this was until they had the second child. So it's about considering what is normal, typical behavior for a child's age, and is this qualitatively different in some way. So with the inattention domain, for that, here the child finds it difficult often to pay attention to details, and they might make careless mistakes. A child with with inattention may present with difficulties in maintaining attention. So they can't it's not just about focus, it's about maintaining it over time. And they may not appear to be listening when spoken to directly, or they may not be listening. They're often easily distracted or forgetful. They avoid or dislike sustained mental effort because it is such an effort. They almost will do anything to avoid doing things that means that they don't like, especially that requires sustained mental effort. Homework's often a big thing here. And they have trouble completing or organizing tasks. And the questions also, the symptom ratings also relate to losing or misplacing things. So here on the left, you can see there's an example of the first symptom in the attention domain. And this is asking, does the child often fail to give close attention to details or make careless errors? And here there are prompts. So the first one here is at home, and down here it's at school. So you're prompted to consider how this symptom is expressed at home and at school. And here you'll see there are brief descriptions for you, the healthcare practitioner, to sort of guide you, to help you assess the symptoms. do not read this out, because they'll just say yes. And that's one of the problems, I think, with some of the other interviews, that it's almost like a checklist. So they get, you know, and they can say yes, yes, yes. And it has the potential, they have the potential to be administered, not as an interview, but more as a checklist. And so it really becomes, they can become a glorified rating scales. So I tried to avoid that by using this method. So this here is asking, is this symptom present? If yes, give examples and probe about how it causes impairment at home. Because it's not a checklist, and we need to figure out if it's present, for how long is it present, and whether there's associated impairment. What is that impairment? It's not just so they make careless mistakes. How has that caused them a problem? Of course, you make qualitatively notes in the boxes, and then you have to decide up here whether the symptom is present or absent at home and at school. So regarding the hyperactivity impulsivity domain, we have different perspectives according to which diagnostic criteria you are using. ICD-10 is currently under revision, and it's widely believed that it's going to come into line with DSM-5, which puts hyperactivity and impulsivity, they put them together and it makes one domain of 9 symptoms, whereas currently ICD separates the two out. It's 5 symptoms or 4 symptoms for hyperactivity and impulsivity respectively. So a child who's hyperactive, if we just take those 5 symptoms, we'd be looking for whether the child's restless or might fidget or squirm. As a result, they may leave their seat when they're not supposed to. The child runs about and climbs in situations when this is not expected, when the behaviour is inappropriate, and I think that's key. It's perfectly appropriate for children to be very active and run and climb about when they're running about and playing with their friends and in the park and in the playground, but there are times when it's highly inappropriate, and that's when a child might be very difficult to control and manage. In essence, it's the kids that we're looking at that are always on the go. The child may be noisy and finds it difficult to settle down and engage in activities quietly on their own. They just can't settle that up and around, charging about, making lots of noise. Again, be careful with females here, because females do have hyperactivity, impulsive symptoms, but they're usually to a less severe degree than males. And again, you'll find more about that in the consensus, which is published in BMC Psychiatry, or if you want the quick route, then you can watch my summary of it on YouTube. So there ICD-10 has 4 symptoms relating to impulsivity. It's also in DSM, but obviously the domain is put together. Here the child is lacking patience and perhaps struggling to wait their turn or wait in line. They don't adhere to social boundaries because they interrupt and intrude on others. So they might not, adhere to personal space. They're going into other people's rooms and, not adhering to social boundaries adequately. So it's not just verbal. They might blurt out answers to questions, not waiting for the other person to finish before they respond. And you can tell that. You can see when they're doing that, because they're sort of thinking about what they're going to say next rather than listening to your response. And they may talk excessively. Females, we said that to make it more female friendly, when asking these questions, the consensus suggested that we may need to think about whether the girls are talking excessively and giggling, because girls are very giggly. They're still making a lot of noise and sort of interrupting a lot. So then you've got to decide whether it's impairing. And so for each symptom, you've got to judge whether it's present and whether it's impairing. And to do that, you need to consider a few things. So first thing you could do is consider whether some kind of medical, social, or educational intervention is advised, needed, or has been put into place. Ask yourself, if they don't get intervention, if you think that they need it, what might be the long-term adverse implications? What are the implications of not getting this intervention? Next, Ask yourself, well, are we seeing this because the person's applying strategies to manage their symptoms? And that might be quite common in people who are high functioning. The thing about strategies and compensatory strategies is that they can be hard to maintain over longer periods of time. They can often keep it together for a short while during your interview, but they can't do it all day when they're at school, for example. Next, ask yourself whether environmental strategies are being applied to manage their symptoms. And what I mean by that is, would the symptoms be present if the parents or family didn't make changes in the environment in order to make them to make sure that they can manage the situation or the task best, or to make it more optimal? So environmental strategies might be, well, you know, it's hopeless trying to go to restaurants, so we just don't go to them. That's an environmental strategy, but that's impairment, because it's not only impairing the child, it's impairing the whole family. So symptoms must be pervasive. They must be, again, remember, not just in one setting, of at least moderate severity, and they must occur in multiple settings. This is the observational section that I mentioned earlier. It's provided after the symptom evaluation, where you can make notes about your observations of the child, or whether you're doing an observation in another setting. I always remember a boy interviewing his mother, and a young boy, he was about 8, and while we were I wasn't doing the ACE, it was a briefer interview. It's when I was at Great Ormond Street many years ago, and but I remember this kid was rolling all over the floor, sticking his fingers in the plug socket. I mean, he was just completely all over the place. And what she did is we got someone to take him out and play with him outside, because he just disturbed the whole thing. It was almost impossible to have any kind of conversation. Regarding the section on comorbidity and differential diagnosis, this is a clinical prompt. It's not a diagnostic interview to go through all the comorbid possibilities, but it does give you a prompt. So you know that you need to be, those administering ACE and ACE Plus are expected to be healthcare practitioners who are qualified to make a diagnosis. Somebody asked me on Twitter actually this morning, can Senkos and other people do it? And my answer to them is, well, yes, you can, but you can't diagnose because you're not trained in this differential diagnosis. So, but you know, but I think I'm developing online training for this, and I think if people go through that and they can download it, I don't see why they can't sort of go through it, because there's nothing to be lost other than your time or their time, and they might learn a little bit more about ADHD and consider a little bit more about ADHD and how it may present in different settings. So the assessor considers whether common differential and coexisting conditions are present, and what they've got to decide is, are they primary? So is this an anxiety disorder? In other words, this is a differential diagnosis, or is it secondary? Is this something that's been here for the last sort of year or so, but these problems have been present since the child was about 9. So in that case, it's secondary, and it's a coexisting comorbid condition. You don't disclose the condition being discussed, but it leads with general questions that relate to the condition before focusing on specific symptoms. I'll show you an example in a minute. If you're applying ICD-10 criteria, please note that if you're applying that classification system at the moment does not recognize comorbid conditions, but it's widely viewed that it will do in the revision. So the prompts are to consider autism, cognitive impairment, tics, depression, mood disorders, PTSD, traumatic brain injury, ODD or CD, speech and language impairment, interpersonal problems, anxiety disorders, obsessive compulsive disorder, substance misuse, other developmental disorders, other physical conditions, other mental health problems. So there are spaces where you can add additional things. So this is an example of it. You come here, and here, for example, with autism spectrum disorder, it gives you a question for you. Is there evidence, it's prompting you, is there evidence of speech delay, problems with forming and maintaining social relationships, social communication, rigidity, repetitive behaviors, and sensory hypersensitivity? So that's a prompt for you as the clinician. Here you can make some notes. Oh, yeah, here you can make some notes. Now, if it's been previously diagnosed, then yes, it's been previously diagnosed. Or you can say, if you're not sure, but there might be something, you can decide whether further investigation is required. I'm not suggesting, I think in reality, what people do is they don't go through every single one, because by the time you've gone through, there's a few things in your mind that you might turn to rather than go through every single one in turn. And certainly when I do it, I tend to think, I get what I call a ping in my head, and I think, oh, maybe there's a few things here about autism, or maybe there's something here that may be an anxiety disorder. So I will kind of perhaps select. But what is good is as I turn the pages, it's reminding me, oh, I haven't checked about substance misuse disorder. You know, it's reminding me about what I may need to make sure I cover. So you can make qualitative notes in the box, decide whether it's present, absent, or possible, and decide whether more information is needed. Then you score and diagnose. So the symptoms scoring differs for DSM or ICD-10. So if it's DSM, you have to have 6 of the 9 symptoms of inattention and 6 of the hyperactivity, impulsivity symptoms. So 6 of inattention and or 6 of hyperactivity, impulsivity. For ACE Plus, it's 1 lower, it's 5 of inattention and or hyperactivity, impulsivity. Onset has to be by 12 years. For ICD-10, you have to have 6 symptoms of inattention, 3 symptoms of hyperactivity, and 1 symptom of impulsivity. And the adult criteria is exactly the same, and onset has to be by age 7. Here is an example of the DSM scoring sheet. So you just transfer your information here to the questions, whether they're yes or no, whether they've been present at home and or at school, and then you total the items there. So then you say whether yes they meet or no they meet those the number of symptoms that are required, and you go through the same process here for hyperactivity, impulsivity. There then follows specific qualifications to make a diagnosis that you need to do, such as, and it prompts you, are these, so because you can have yes in both of these, but one of these might be a no, in which case you do not make the diagnosis. So the questions are these symptoms found in more than one setting in more than one setting? Were these symptoms present before the age of 12? This is the DSM one. Have these symptoms been present for 6 or more months? Are they impairing the child's functioning and development? And are they better explained by another condition? That's the differential diagnosis side. Then you decide whether it's predominantly inattentive, hyperactive, impulsive, or combined. And the ratings up here will guide you to that. There's a lot of information, there's a whole load of information about how to do this in the manual. Sorry, not the manual, it's not a separate manual, it's in the tool. And for ICD-10, you go through the same process if you want to use the ICD classification system. And of course here, we're separating out inattention, hyperactivity, and impulsivity. So briefly, just to pull out the differences with ACE Plus, who is interviewed? Well, you interview directly the interviewee, whereas you're not interviewing their parent now. But you should also try to get independent information, and this is really helpful if you can get, and you'd be amazed at how many parents keep school reports. But don't just look for school reports if they've been involved with social services. Or at work, there might be occupational reports that are very helpful to assess an adult, like appraisals and what have you, and written things and performance reviews, that kind of things. Very helpful information to have. It can be hard, though, for the user to think back to their childhood, and that's why this school information is very good to supplement the account where appropriate. It can be difficult, admittedly, if you're reliant on self-report or in the absence of records. And I often find that, especially with some of, I'm a forensic psychologist as well, and working with offenders, often it's very difficult. You've only got what they're saying now, and often they don't communicate it very well either. So in this case, you really do need to pick out and be very careful with differential diagnosis and comorbidity. Of course, they have to have had it in childhood first. So now you're assessing an adult, but your first question is, did this person have ADHD in childhood? Now, if an ACE has been completed or something else that you're happy with and it's a good fundamental, a good clinical interview, if it's been previously completed in childhood, then you don't need to repeat the child sections in ACE+. Okay, so, and you just record the information about where you got that information from, but you would only use that if you're really happy and confident that it's a good, reliable clinical assessment that was done in childhood. The background that you do, there's a background section, and that's very similar to ACE, so it's not a lot different. With the symptom, with respect to the symptom ratings, ACE Plus targets the same 3 symptom domains. It guides the clinician to assess each of the domains as ACE Plus, as in the same way ACE does. And if that client hasn't been diagnosed with ADHD before, then you've got to consider how each of these symptoms manifested across childhood as well as adulthood. And that means you've got to consider how they presented at home, in their educational, and currently in their occupational environments. Bear in mind that when you're looking at, when you're assessing a child, you're considering, educational environment, you're thinking about their educational performance and behaviours. But when you're faced with an adult, you're looking at all occupational activities outside of the home, such as paid, including paid voluntary work, sports and social activities. So this is an example of ACE Plus. So here you see we've got, this is the probe about whether the symptom was at home in adulthood. We start with adulthood because people tend to talk about now, what's happening to them now first. So is this present, was it present in adulthood in the home? Is it present in adulthood in their occupation? And then you go back in time to the childhood. Was the symptom present at home in childhood? And was it present in childhood at school? So again, you don't read out the descriptions. They're just there to prompt you to, and I would start by getting them freely to give you the information and then start to prompt. Again, it's not a checklist. Make notes and decide whether it's present or absent in childhood, at home and school, or in adulthood, at home and in their occupation. Observational. The observations are similar to ACE. You might record things that you notice and behaviour during the assessment. With respect to comorbidity and differential diagnosis, this is not dissimilar to ACE, to the ACE, but there are some adult conditions that we also need to be mindful of, and those include personality disorder, bipolar disorder, psychosis and emotional instability. And I think the most common personality disorders that I've come across are borderline and borderline usually in females and antisocial in males. Interestingly though, sometimes I think that's it's not a comorbidity, it's a misdiagnosis. I've come across, we did a study once in females in a borderline offending unit where many people, an offending unit for females, and many of them had a personality disorder. And when they were treated for ADHD, the treating doctor told me that it was amazing because the personality disorder seemed to disappear. And what it was is that it was misdiagnosed personality disorder instead of ADHD. So again, you score and diagnose. First of all, you'll be scoring for childhood in DSM, because you remember your first question is, did they have this as a child? And this is in the ACE Plus. Did they have it as a child? You go through this, and if you've got a yes here for childhood, then you score and go through and rate, did they have it? Do they have it as an adult? So in the same way as ACE. ICD-10 as well has similar sections. Of course, at some stage when ICD-11 comes through, we're going to have to change all of these in different languages, but we will. So this leads us to my work with BrainGaze, who were interested in developing an online platform for ACE and ACE Plus. These are great. I've used it myself. They're for completion. You can complete it on a PC and now rah on a Mac, and also associated products like an iPad or a phone. It's currently available in English and Spanish online. Hanti's going to tell you all about this. But the good thing is it gives you the automatic scoring, gives you the option to generate a hard copy of your notes, so you can print those out. So as a clinician, I know that that's what I want from that. So you can put them in your files to justify your decision. You had the option to generate a report, and you can add to that report. It's in Word format, I think, and you can add to it and, you know, make it as long or as short as you want, but it has the basics there. And if anybody's interested, I think, in exploring whether this could be done online in other languages, you need to, I don't have anything to do with that. You need to contact BrainGaze about that. Just briefly, just to tell you in the last few minutes, I recently developed ACE and ACE Plus pre-assessment tools. And again, these are also free to download on my website. Some of the translations are currently are coming through. We've got it in Norwegian. We've got it in, I think it's currently being translated into Turkish. Hello, Turkey, if any of you are on here. You know, so we have, and the reason I developed those is because, again, I wasn't very happy with the rating scales. So what I did was, this is an example of the ACE self-report, and there's an ACE informant report. So I can send these out to them, and it has a rating scale. So over the last 6 months, have you failed to give close attention to details or made careless mistakes, for example? And then they can decide whether that's never, rarely, sometimes, or often. And they also can say don't know. But then they're asked to justify, to give it a rationale, give an example of what that means. What is it that they do? How does that affect them? Because that's the information I want to have, because I think with rating scales, it's too easy to go tick, 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 tick. And sometimes you've got one symptom that's rated in about 5 items. And there is some overlap, it's true, with some of the symptoms, but it's about how's this impairing, and it guides my assessment. To get this information in beforehand is really helpful because it guides my assessment. You can also, with the online version, you can get rating scaled information this way, but I think it doesn't include the examples. But if you want that, then just, you know, just remember just to ask them, or download these, and you can send these out in paper version. Here's the example, exactly the same for the ACE Plus. So just to say, I mentioned earlier that I am developing online training for this because of COVID. I'm not able to go out and do training. I get asked, I do go out to different places in different countries and do training, a one-day training course in administering ACE and ACE Plus. I show videos and we score and rate and we discuss it. But the online, now I'm developing online training, and that hopefully will be available in the new year. If you want to hear about that and when that's available, you need to register for notification about training resources. And I also give information about publications like the consensus and the YouTube stuff. You have to go to the contact us section of my website, and that is my website, www.psychology-services.uk.com. Don't worry, please, about getting 50 million emails, unwanted mail from me all the time, because I can absolutely assure you I don't have the time to write it all. So, you know, if you register, you'll hear and be given information about it. I couldn't resist this with the audience, just to let you know that earlier this year I did launch a very similar assessment called DAISY, the Diagnostic Autism Spectrum Interview. It's free to download. I think it's the only thing that is free in just one of the few things that's free in the world of autism. And you know, and translations are already being undertaken of DAISY. So just take a look at that if you're interested. There is a 21% overlap between ADHD and autism, and that was found by meta-analysis that was also published earlier this year by Jack Hollingdale. So this is where you can find me. This is my website. This is my Twitter account. And this is my YouTube account where you can find other videos. Thank you.
Thank you very much, Susan, for an extensive explanation of how ACE and ACE+ can be used. And especially, I think the examples you gave kind of make it really hit home on the importance of not just ticking boxes, but actually getting to the bottom of things, which is where I think a structured interview excels and where it adds value beyond, let's say, the typical thing that you can just tap into a screen or fill out in one piece of paper. We're already getting quite a few questions and hands being raised. I must say that it's difficult to respond to each of these questions individually. One thing that keeps recurring is the request if the slides could be made available. What I would propose is that we ask the speakers, both of them, if they are willing to do that. And if so, then we will send to everybody who registered for the webinar a link to download these slides. If they would prefer to only make a limited selection of those slides available, then we'll also inform you of that. Other than the slides themselves, there is definitely the possibility to revisit the webinar because it's being recorded and we will publish it on YouTube, and you should be able to find it both on Susan Young's YouTube channel and also on BrainGaze channel. For any other questions, I would propose we first move along to the second speaker, Hans Supèr, and then at the end of both talks, so after Hans has done his presentation, we can have a short Q&A. Please use the chat or the Q&A function of Zoom to type in your questions. So I will be able to take a look at them, the panelists can see them, and we can kind of manage to give the appropriate answers to those questions that are most interesting for a broader audience. So thanks very much, Susan. I would now suggest, Hans, you pick up where Susan left it. I think she kind of put the ball right where you can pick it up and explain what the advantages are and the specific functionalities of the digital versions of ACE and ACE+. So Hans is my co-founder in BrainGaze. I'm the CEO, Hans is the CTO. He's also, perhaps more importantly, a PhD in neurobiology. He's been working for 25 years in cognitive attention, specifically in the visual domain, but also beyond that, and has basically discovered the digital biomarker that BrainGaze uses for its objective ADHD test, BGaze Clinic. We're not going to talk too much about that particular test today because we're focusing this webinar on BGaze ACE, but also in BGaze ACE, we have actually managed to put in a lot of digital smartness that would allow you to enhance basically, the use and the accuracy and the reliability, specificity and sensitivity of the existing tools. So without further introduction, I would say, Hans, please start sharing your screen and take it away.
Okay, thank you very much, Laszlo, for the introduction. Yes, also thank you very much, Susie, for your clear and nice presentation of the ACE. I will keep it short, so please bear with me for this last few minutes. I will talk about the BGaze. It's called BGaze platform that now includes Susie's ACE and ACE Plus. It's a cloud-based platform. It means you can run it on any browser or tablet or laptop or even on your mobile phone. If you want to play around it, you can go to this link here. You have a 3-month free trial just to test and to find out whether it's suitable for you or not. Once you register, you get your username. It's in different languages, English, Spanish, but also in Dutch and in Chinese. So once you enter, then you go to the let's say the main menu, the menu of the patients. Here are there only 2 patients and a demo patient. You can add new patients. If you click on a patient, then you go to the, let's say, to the main menu of the BGaze platform. Here we have the clinical interview, ACE or ACE Plus. It automatically selects the correct one. So if the child is above the 16 years of age, then it will be the ACE Plus, and if it is younger as a child, then it will activate the ACE. There's also the BGaze therapy. I will not talk about this in this session. It's an interactive eye tracking game designed and validated to improve the attention symptoms in ADHD children. And thereafter, we have the reports of the clinical interview that collects all data that has been introduced in the platform. So these are the different sections of the ACE, as Susie already explained. You just click on it and then you go to the page. Let's say go to the background. Oh wait, before we, throughout the whole platform, the whole interview, there are question marks. If you click on it, there is a window popping up. Gives you background information to help you how to fill out the questionnaire and what is actually is being asked and what you have to fill out and so forth. So if you click on one, you get the different items of the ACE. This is of the background. If you click on it, you get all the items that are part of the ACE interview. You just check the boxes that you think that are adequate or you have to appropriate to fill out. You have here everywhere in all sections you have text boxes. You can fill out the text whatever you want. You can change it afterwards. There is no save button. Everything is automatically saved, so there is no risk of losing any information. If you go to observations, there is again a text box where you can put all the information that you have done about the child or about the patient. You can put the time, when it was, the person who did it, and so forth. Then you have the differential diagnosis. It's about for making whether it's a primary disorder or secondary. As Susie already explained, you just click on the item, it pops out a window, and then you can tick the boxes and fill out the description, and everything is automatically saved. If you go to symptoms, there is there on the left side around here. Let's see it here. Yeah, there is an arrow. If you click on this arrow, there is you can send out the rating scale to different informants. Typically, a parent is asked and a teacher is asked. But as Susie already explained, you want to have as much as possible information about the child's behavior in different environments. Could be important if parents are divorced, they are separated, living in different homes. So the child is partly living at the mother and partly at the father. So they will have different environments. Also at schools, nowadays you have different children have different teachers, not only the one, but there are different ones. So you like to have the opinions of different teachers, but also it could be the music teacher or the football trainer. So you can send out up to 6 informants, and so you get a much better view, let's say, about a child's behavior in different environments. once they filled it out, you get automatically notified within the platform that that you received the information. And once you have received everything, then you just then you know that you can continue with the interview. Yes, and I need to say also that the information that you receive from all these informants is visible during the clinical interview that you're doing. So you have the information from the different informants, the different environments you have visible when you do the interview. Once the informant receives the email, it contains a link. Just clicking on the link, you go to the page. You receive just by ticking the boxes, you answer these 18 questions, and then it's automatically returned to the platform for you to have this information. So there's no need to make telephone calls or to send emails or to get parents returning the information and so on. So everything is automatized. But these are the 18 questions. You can do it in order, you can do it just randomly, whatever. Just click on it. Once you click on it, you get it opens the page with the questions. As I said, here, and here, there are only 2 informants, but these are the responses of let's say the parent. Actually, it's myself, but it's a demo, and this is of a school teacher. The boxes represent, let's say, the response of the informant. In this case, it has responded by always. I mean, the responses to each question can be never, just a little, quite a bit, or always. But whether the teacher just responded by just a little, so there's a discrepancy between both environments. Here you have to respond, so just click on it. You can change it. If you change your mind, you just click on another one. It's automatically saved. Here you have to fill out, this is a text box, you have to fill out why you think this is the correct answer. If you have doubts, you need help, you just click on the question mark here, and then a window pops up to give you a little bit background information and support you to make a good decision. Then we have the scoring sheets, the DSM-5 and the ICD-10. They are automatically filled out by the platform. They are separated in DSM-5 in the intention and the hyperactivity domain. These are the home environment, this is the school environment, and this is your assessment, so the responses of what you made. Red is that the symptoms are present, green is that symptoms are not present. And automatically it adds, and if it is, it meets, let's say, the criterion, then it automatically fills out whether these symptoms are present or not. And it does so for the DSM-5, it also does for the ICD-10, that have different domains. So there is no, let's say, there's no risk of making an error if you just in a hurry or what, that you just miscalculate the number of items. So then we go to reporting. A report is automatically generated right after you finish, let's say, or when you think you want to have the report. You don't have to finish the whole clinical interview. You can generate a report. Meanwhile, if you change text, if you change something, some answers or some text boxes or whatever, you can update it. So you have always the latest version. You can save it. Generated 2 reports. One is a clinician report, we call it, and one is a summary report. The clinician report contains all information you entered in the ACE questionnaire. So all text boxes, all text, everything. It's therefore a very long one, but at least you have all information. You can save it as a PDF. Also interesting, I think, is here we have a small logo. Within the platform, you can upload your own logo. You can give a description of your clinic, and then once you generate a report, then your logo will be present here. So it's more personalized for your clinic. So the ACE, this report also gives the final score. As Susie told, you have to check the questions whether this symptoms can be explained by another disorder or other condition, or whether they are present before a certain age and so on. If you do that, then automatically the platform gives the correct answer, whether it's ADHD, in which kind of domain it is. It does so for the DSM-5. It does also for the ICD-10. And interesting, it does it also for, we made a what we call the BGaze probability score. I will briefly explain how we got this probability score. I make a small sidestep to explain this. What we did, we have a biological marker, a neural marker, a biomarker, let's say, of attention, and we validated clinically with an academic hospital to see whether to prove that we can predict, let's say, ADHD with this biomarker. And there was done a very thorough clinical diagnosis of ADHD, and a part of this diagnosis was the rating scales. So what we did, we compared the responses of the rating scales to the final outcome of the extensive clinical diagnosis. And if you look at just at the DSM-5 scoring, we see that the rating scores give a quite good, actually, an 82% accuracy, which actually in our case is quite good, because there are papers out there that give much lower scores. Give some false negatives, but it gives a huge amount of false positives. It means that there are healthy children, they don't have ADHD, but the scoring sheets were just incorrectly actually filled out, because they gave too much high scores, and therefore the diagnosis was ADHD. So what we did, instead of like what DSM-5 does and what the ICD-10 does, is just summing, let's say, the positive scores when the symptom is present, and then to sum it, and when you exceed 6, then you have ADHD. If you score 5, then you don't have ADHD. So what we did, we applied artificial intelligence, machine learning, to make it a calculation a little bit more clever. So what we did, what the model does, it actually is just to give a weight to each question. So not all questions have the same value. Some questions are more important than other questions. And then this model, and then we made a matching with the final clinical diagnosis. And by doing that, we got a similar accuracy, a little bit more higher, but quite good, okay. We also got a similar rate of false negatives. But what we observed is a huge drop in the number of false positives. So we could discard a lot of, let's say, healthy children that were otherwise diagnosed of having ADHD, well, they actually did not have ADHD. So we give this as a probability score. So that's a gradual score. It's not a yes or no answer, like the DSM-5 or the ICD-10. But it gives a gradual score that you can use as the interpretation for having ADHD or not. So we give also this score. Then we have a summary report. That's a 3 pages report that is already pre-filled with text, with an introduction, and with the final outcomes. You can share with your patient if you want, or you can add it to the patient dossier. The importance, I think, what we feel it's important of this short report that is automatically generated and pre-filled, is that you can download it as a Word document. Then you can add and change text, and you can make it very personalized for your patient, and that just saves a lot of time and effort from as a clinician. So we digitalized, let's say, and we added some information to the ACE clinical interview from Susie. If you want to know more about BrainGaze or about ACE, please go to our website, BGaze.com. And if you think you like to try the ACE, our platform, you can have a free trial for 3 months. Just go to this link, just register, and then you can start trying it out. And let's see if you like it or not. Yeah, so that was my short presentation, and I will give the word back to Laszlo.
Yes, thank you very much, Hans. Yeah, I think it's, well, of course, very nice to see how actually not even that complicated artificial intelligence is able to reduce false negatives by factors 3. We're only, of course, at the beginning of this whole science around how artificial intelligence can basically improve the decision making that in the end is a very tough job to do if it's reduced to simple arithmetic. I think that's also, of course, the benefit of the structured interview, where it's not just a matter of arithmetics, but you get the qualitative remarks that can help you guide in your final decision. There's a couple of questions that have been coming up. I think also some of them have already been answered. Online, I would say some people are asking questions, and maybe this is more towards Susan, about either the severity or the qualitative aspects in answers that the professional receives. How these are taken into account. So how are these then finally processed into the quite digital yes or no box ticking or not that ultimately needs to be done, because that's what ends up in the scoring cards. Could you give some comments on that, Susan?
Yes. The qualitative information that you've written, they're like your notes. Okay, so you have to decide, whether, based on what you've written and what you've heard and the information that's coming in, you decide whether that symptom is present or absent at home or at school or in someone's occupation. So you decide on that, so that you don't analyze the qualitative data as such, but it's the information that you've got, just the same as if you're not using ACE or ACE Plus. You're assessing something, you're asking questions, you're getting the information, and you decide whether it's fitting a diagnostic classification, whether whether the pattern is there that you are looking for. So that's the purpose of it. But of course, it's very useful to be able to print out your notes and to have those recorded somewhere.
Okay, thank you, Susan. There was also another question, which I have the feeling you would be the best qualified person to answer, which is if there's any specific way that these tools, ACE and ACE Plus, take into account the differences between males and females with regard to how ADHD could manifest itself. I think you made some comments on that. Could you expand that a little bit?
Yeah, they weren't, ACE and ACE Plus weren't developed with different, just as the diagnostic criteria is not developed with the difference, with the sex difference in mind. But I mean, if you read the female consensus, which, as I said, is free online, and I also talk about it on YouTube, it will be informative, because I think what we're starting to learn, I mean, it's only taken us about 25 years, but we're starting to learn that females, present slightly differently to males. I mean, there's a lot of heterogeneity in the symptoms of ADHD, but they do still have. I mean, it's a myth, though, to think that the boys have externalizing conduct problems. And the girls all have internalizing problems, and the girls are all inattentive, and the boys are all inattentive and hyperactive, impulsive. They're combined type. In fact, what the data suggests, that actually they both have internalizing and externalizing problems. They both have a broad range of symptoms, but the female presentation may be slightly less severe in terms of symptoms. And that's why we did suggest certain, qualifications for assessing females, like thinking about girls being giggly and what have you. But also, it's how these difficulties are expressed is different. You'll see a really nice slide that I have if you go to the YouTube channel and look at that. There's because it's how it's expressed that's different. The boys are very much like, you know, how it's different is the boisterous boys. There's much more aggression, there's boisterous behavior. Females, though, all the difficulties with females were much more social relational, much more, you know, in terms of their relationships and how they interact with people. And that was much more prominent in terms of their difficulties and their problems. And that's where females it might not be captured in what the teachers are saying, in what the teachers are observing, because they might disregard it. And teachers as well might also feel that the boys are more typically presenting with ADHD, because that males, you know, perpetuating the myth that males are more likely to have it than females. So I think we don't have a difference in the actual assessment. We don't have a difference in it for advising about males and females. If I was to do it again, I'd probably, now that I know a bit more about that, we're starting to learn more about females, I might put a paragraph in to give a bit more advice about what to do with females. But what you do need to do is focus more on social relationships, and rather than fundamental aggressive hyperactive behavioural problems that you look at with males.
Okay, thank you very much for that answer, Susan. I actually found a question that I'm happy to be able to answer myself for a change. Which is whether or not the pre-assessment tool of ACE and ACE Plus that automatically populates the ACE and ACE Plus interviews, where I can basically say that, of course, for the paper versions, this is not the case. You would need to take these pre-assessment information that's given on paper and migrate them to the paper version of ACE and ACE Plus as structured interviews. Of course, the rating scales that informants fill out on their smartphone or on their tablet, which can be up to 6, those do get automatically populated into the ACE and ACE Plus online version, so the BGaze ACE and ACE Plus. So if you use the digital version, this will automatically appear, and it will also appear on the screen where you're asked to value that particular symptom yourself. So that's what Hans explained. So basically, if you're looking at a certain question within DSM-5 rating scales, then in the same screen where you're supposed to type your assessment, you will see what the informants have said. So that should make it easier also for you to do final judgment for yourself if the symptom is considered to be present or not present. There's another question here, which is regarding inter-rater reliability for ACE and ACE Plus. Susan, is there any data on that? Is there any research that has been done on inter-rater reliability of this tool?
There is research that's currently being done. I think one set has almost been finished in Hungary about give it a validation of the scales, and I'm not sure whether inter-rater reliability is included in that, but there is a validation. You know, I'm not involved in the research project because obviously it would be considered I'm biasing it. And it's frustrating because I keep asking them, what are the results? And they keep telling me to be patient, which is not one of my best qualities, but it is coming. The data is coming. And what is the inter-rater reliability between different clinicians doing assessments of ADHD who are not using semi-structured interviews? And there is an argument that these types of tools don't need validations because they're following the diagnostic criteria. I mean, a lot of people do them against, I think it's the kiddie SADs and stuff, but in fact, when I started to look into it, that hadn't ever had an actual validation against clinical criteria. I think that was the run that I was looking at, but it's a commonly used tool. So there is an argument that maybe it's not necessary, but we're in a world where we want validations of everything and we want to be sure, and that's a good thing to do. So yeah, this information is being obtained in several different countries, and it's going to be a question of who comes up with what first.
Okay, thank you very much, Susan. I think given the time, it's now 8:10, and I think we kind of promised people it would be about an hour that we would take of your time. I just wanted to close off with one final remark, which is also an answer to a question that was given, which is whether we will also go into the other products that Hans mentioned very briefly, the BGaze therapy tool and the BGaze clinic tool. The answer is yes. We are regularly organizing this kind of webinars to explain the tools that we offer to psychiatrists, clinical psychologists, basically anybody who's working in this space. So yeah, keep tuned. We will probably send you a reminder when this other webinar will take place on BGaze therapy and or BGaze clinic. Yeah, so we'll make sure that you can also learn everything there is to know about these different tools that we've recently put on the marketplace. There's a couple of questions which are very specific going into comorbidity of ADHD, which I feel are interesting, but maybe more interesting for the particular person that asked them. So I would propose that we'll pass on these specific questions to Susan, and maybe she can write an answer in a few sentences, which we can then pass on to the person who asked that question. I would propose for now that we basically terminate this webinar for the sake of time, for the sake that it's also in the UK now getting ready for dinner time, I guess. I can only thank very much Susan for allowing us to have you in this event. Hans, of course, for explaining from a neurobiological and AI point of view, the value of BGaze ACE as an online version. And also, of course, very much big thanks to those that are still connected, which is an awful lot of you. We're very happy that we see that there's a big interest in these kind of webinars, and that will only stimulate us and confirm that we need to organize this on a regular basis. We are doing that, and we will do that even more in the near future. So thanks very much, Susan. Again, thanks very much, Hans. Thanks very much to all the attendants, and we'll keep you posted of future webinars as soon as they appear. And we'll also let you know when and where you can actually view the recording of the webinar on YouTube, either Susan Young's channel or at BrainGaze channel. And we'll have a look at which slides we can make available also to those people that have attended the webinar, so you may use them in your internal organization or whichever purpose you see you would like to have them. Thank you very much, and have a pleasant evening, I would say.